All right, so I have the pleasure of introducing Dr. Bryan Huffman. As just out of interest, how many of you have Dr. Huffman as your doctor? Okay, so a good amount. All right. Born and raised in West Michigan, Bryan Huffman attended the University of Michigan for both his undergraduate and medical school education. He completed his ophthalmology residency at the University of Florida Shands Eye Center and returned to West Michigan to serve the eye health needs of his home community. Huffman is perhaps best known locally as an open water swimmer. What's your next race?
July and August, Lake Huron and Lake Superior.
Oh, man. Okay. He recently completed the Sports Triple Crown, the English Channel, Catalina Channel in California, and the 20 Bridges swim around Manhattan. Please welcome Dr. Huffman.
Well, thank you for having me. It's an honor to be here again to speak with you. So yeah, I'm with Sight Eye Clinic in Holland, and someone asked earlier, you probably recognize our building there right next to Van Hill Furniture. We used to be right next door to the hospital. Before that, we were on. I've been with Sight Eye Clinic for this is my 20th. My partner is Dr. Leisner in the middle there, at the other end. So we use Dr. Bass for my fourth part. And then, yeah, many of you are the swimming doctor. But I'm here today to talk about the aging eye. And aging, where do we start? What is aged? Well, I thought we'd just start at the beginning with babies. And how do babies see? That's one of the questions that we get asked a lot of times is how much can a baby see? And actually, when you're born, you have to learn to see, just like everything else. So you're not born with 20/20 vision. Babies are actually legally blind on the eye test. Most babies are born with about 2400 vision. And when we assess babies' vision, we're really looking for them to be able to look at a target that's close to them, that's big that they can see, and that they follow it with their eyes. Is the main thing we're looking for. But there's a whole lot of complex connections involved with the brain, and about a quarter of the brain is devoted to vision or different functions of the vision. So the back part of the brain, the part in blue there on the screen, is the occipital lobe, and that's entirely for vision. And then there are many connections, as you can see in this other diagram, that go with other functions, like interpreting what are you seeing. Reading requires a whole lot of brain function. So there's a lot of things that go on. A big part of the brain is for vision, and all of those neural connections have to develop from birth. So when babies are first born, like I said, their vision is very poor. They're seeing roughly the big E on the eye chart or less. By 6 months, they're down to about 2150. And really, kids in the office, if I see 5-year-olds and they're seeing 20/30, I still consider that to be normal vision. Part of it is cooperation on the eye exam on when do they just decide I'm done with this. But yeah, kids, 3-year-olds seeing 20/30 is fairly normal. So for them to see, tiny details far away, they don't see them till they're quite a bit older. So it's not just something you're born with. And then one of the other tests I get, or one of the other questions I get asked a lot is, what does like 20/20 or 20/30, what does that really mean? And the first number is the testing distance. So here in the US, we usually use 20 feet. In Europe, actually, they go by meters. So it's 6 is their first number for 6 meters, which is about the same as 20 feet. And then the second number is how far away would a person with normal vision be standing to be able to see that same line. So if you have 20/40 vision, what that means is you're seeing from 20 foot away what someone with normal healthy vision can see from 40 feet away. They can be twice as far away and see the same line. So it's actually, and they're divisible like fractions. So 20/40 is twice as big a letters as 20/20. 2100 is 5 times bigger. So those are what those numbers mean when we're looking at an eye chart. The other question a lot of times we get asked about kids is eye color. Does that eye color change, and eye color, is it established at birth? And like a lot of other things in the body, actually, the color of the eyes is not done developing when we're born. It develops after birth. And so many children, about a 25 to 30% of kids will be born with blue eyes, despite the fact that brown eyes are but the most common. And that color will change. And color is determined by one pigment. There's not a bunch of different color pigments in the eyes. It's brown. If you have no pigment, your eyes will be a very light blue color. And as you get more brown pigment, the color will shift away from blue to more brown. So hazel would be, kind of partially blue, partially brown. Interestingly, green eyes, it's not just the pigment that makes the color, it's how light reflects off the iris. And so green is created by how light reflects off the iris and makes the colors look different. And it's the least common eye color. Evolutionarily, they say, I'm not sure how we really know this, but that actually everyone had blue eyes before, brown eyes before 10,000 years ago. And essentially, there was a mutation that caused pigment not to develop in the iris and created blue eyes. And then that mutation is permeated throughout society where people have varying amounts of it. And your eye color is not really directly correlated with your parents. You can have two parents with blue eyes and a baby with brown eyes. You can have two parents with brown eyes and a baby with blue eyes. It's much more complex than just individual genes, so it's hard to tell. But it's fairly common if you look at a birth certificate that has eye color on it, that it might say blue eyes and you're an adult and you have brown eyes because they change from when you're born. Oh, sorry, these slides, the top's a little mixed up there. Yeah, so I kind of talked about all of this already. So usually eye color is established. The most prominent change is between about 3 to 6 months of age. And usually by about 9 months, most babies will have a pretty good idea, what the eye color is going to be, but it can continue to change. And actually about 15% of people, your eye color will change through your whole life. But you can have, certain color eyes at, 16 and it's different when you're 40. But usually not big changes from that point. Mostly it's established by around 9 months or so for most kids. So what about glasses, refractive error? So another thing we come upon often in the office is kids in needing glasses. And most children will be born farsighted. And farsighted just means you have a plus prescription for glasses. Nearsighted is a minus prescription. And most kids are born about 2 to 4 units farsighted. Now, kids have a huge ability to focus their eyes that we lose as we get older. So kids are born with usually about 16 diopters of focusing power. A diopter is, one diopter is 1 meter. 16 diopters is 1/16 of a meter. So it's basically about 1.5 inches from your face is how close young kids can focus and make it clear. And so to focus 2 to 4 units is no problem. Usually if it's about a half or less of your focusing ability, you can make it clear. And so kids that are 2 to 4 units farsighted usually don't have any problems. Now, if you're born more farsighted, usually 4 to 5 or more, what will happen is there's a natural reflex. That is, if I look at my finger or look across the room and then look at my finger, what you'll notice, it looks like my eyes are crossed because your eyes have to turn in to see that target. And there's a reflex with your focusing that causes your eyes to turn in. So if you're focusing 4 diopters, your brain thinks you're focusing at something right here. And if it's enough of a prescription to have to focus on, it'll kick in this reflex that the eyes will turn in. And so we'll see kids sometimes that have what we call esotropia, where one eye is turned in. It's actually an issue where both eyes are turning in, but if they're both turning in, you're not looking at your target. So the brain will pick one eye to look with, and the other eye will turn in even farther. And so typically there'll be one eye. Sometimes it'll vary which eye it is. But if this is uncorrected, it can cause problems with development of good vision. Essentially, the child will shut off the eye they're not using, and they won't develop those normal neural connections that you need to learn to see, and they won't learn to see in that eye. And if we catch that early, the fix oftentimes is just a pair of glasses to do that focusing. We do that 5 units of focusing, and now all of a sudden it turns off that reflex because we're doing all the focusing work. The eyes will turn back out again and it solves the problem. If it doesn't, we can do eye muscle surgery to fix that. So the top diagram here shows what farsightedness looks like, and it shows why kids outgrow this. So you can see in normal vision, if we take light that comes in, it's focused to a point right at the retina. When you're farsighted or hyperopic, it's focused behind the retina. The eye is too short. Well, what happens as you grow? Your eyes grow. Babies are born with fairly big eyes. Their eyes are about 2/3 of adult size when they're born. Your eyes grow less than a lot of the rest of your body, but as they grow, you outgrow this farsightedness as the eye kind of catches up to where the light's in focus. And then some will go on to become nearsighted or myopic, where now the eye is too long. So if the eye keeps growing and just keeps growing too long, you become nearsighted, and that's the most common prescription we'll see in adults. And that change usually happens around 8 to 12 years old. So that's a very common time. We'll have kids come in when they're in like upper elementary school and they start needing glasses because their eye has gotten bigger over time. And then usually about the time you're 20 years old is about the time prescription will start to stabilize for most people. Some people will continue to change, and a small percentage of people will just continue to get more nearsighted over time. And that does tend to plateau. So I'll commonly see people that are fairly nearsighted where their prescription just keeps increasing. And they'll reach a point where it kind of stabilizes. And a lot of times it'll actually start going the other way as you get older. So it changes throughout your life. But yeah, commonly starts out farsighted, reaches 0 about 8 to 12 years old. And then many people go on to be at least a little bit nearsighted, but not all. So the other part of prescription I get asked about is astigmatism. And what is astigmatism? And people come in thinking that, oh, somebody told me I have astigmatism is this bad problem, and it's like a rare thing, and it is not. Almost everyone has astigmatism, and it's just part of the glasses prescription. So the first part we look at is, are you nearsighted or farsighted? And then the other part is, do you have astigmatism? And astigmatism you can think of, it's really a measure of sphericity of the eye. So if your eye it's really not perfectly spherical, but if it's symmetrical, like a basketball, where it's spherical, you have no astigmatism. The curvature is the same everywhere. Astigmatism, the analogy I always use, is a football. The curvature in one direction is much steeper than the other. So this football vertically, the curvature is very steep, but horizontally it's fairly flat. That's what astigmatism looks like. But your eye's not shaped like a football. People come in and say, I have football shape. No, it's not. It's really more like a basketball that you're squeezing. So this guy's crushing this basketball in. It's going to shorten the length horizontally in this case. So it's going to make that steeper in that direction and flatter in the other direction. And that's really what astigmatism looks like. When you look at the surface, yeah, it looks round. You can't see it just looking at it typically, unless it's really severe. But so most people will have that because most people's eyes aren't perfectly spherical. And that changes over your lifetime as well. Most people will be born with astigmatism. We measure it at the axis of the steeper curvature. So in this case, this football would be a vertically oriented astigmatism because the steeper axis is vertical, and the two axes should be 90 degrees apart from each other. And typically you're born with astigmatism that's vertical, and then over your lifetime, it tends to shrink and then increase in the other direction. So most kids that come in with astigmatism, a lot of times it will decrease some as they get older. Again, it depends on how much you're born with if it goes away. And then commonly as folks are older, we'll start to see horizontal astigmatism that will increase a bit over time. Presbyopia. So as we continue to age, so we're out of the infants, past 20, and now we're starting to get about 40 to 50. All of a sudden, everybody starts to need reading glasses. And that's the other part of your glasses prescription as well. Oops, sorry, backed up there. So presbyopia is the loss of what we call accommodation. And so I talked earlier about kids being able to focus up super close, that they have about 16 units of focusing power. And what causes the eye to focus is there are muscles. So in my picture up here in the top right, we see the cornea, the iris, and the lens is this kind of roundish clear part in front of the red area there. The lens is held in place. You can think of the lens in the eye. There's a membrane that surrounds it that you can think of like a plastic bag suspended in the eye. And it's suspended by little tiny fibers we call zonules that connect to a muscle that goes around the circumference of the eye. It's called the ciliary body. But when those muscles contract, that ring of muscles gets smaller, shrinks. And as it does, it's pulling on these little zonules that pull the lens out more flat. When it constricts, the edges of the lens start to come in smaller and the thickness of the lens increases, and that changes the shape of the lens in the eye. And that's what allows you to see up close. Some complex things that go along with the loss of accommodation, but what I will usually explain it to patients is the lens gets more stiff over time. So it's super flexible when you're first born. So if a kid wants to look at something up close, if a 2-year-old wants to show you something, they hold it here because they can see it. They can literally focus like 2 inches from their eye, and they don't understand why you can't. But from birth, we slowly lose that ability to focus. So second graders will sit reading with their desk, with their fist holding their head up like this, 3 inches away, and they can do that no problem. But that closest you can see something slowly moves farther and farther away, and it starts from birth in everyone. And it doesn't really bother you, or you don't notice it until it starts reaching your normal reading distance, which is somewhere between 40 and 50. And then you got to hold things farther, and then your arm's not long enough. And then, well, how do we fix that? Well, we do that work for you with a pair of glasses, a pair of plus power glasses that move the focus in closer. It takes, if you are in perfect focus for distance, it takes about 2.5 units of focusing power to see something at a normal reading distance, less if you tend to hold it farther away. And so what we'll start with is a fairly weak power of reading glasses because you can still do some of that focusing on your own. It gives you a nice big range you can see over. But as we lose that focusing power, we need to keep bumping up the strength of those reading glasses to do more and more of that work. But once we hit about 2.5 units, if your starting prescription is 0, we don't need to keep increasing it because now we're doing all the focusing for you. The one way around this is if you are nearsighted. So if you're born nearsighted, you're born in focus up close. Depending on how nearsighted you are determines the distance. And so people that are nearsighted will sometimes take their glasses off to read because they're just naturally in focus at that distance, but then they need them for far away. So you need them for one or the other eventually for everyone. So as we continue to progress throughout life, one of the next things we'll see is something called a vitreous detachment. And this usually occurs in people, I start seeing it oftentimes in people in their 40s or 50s, through their 80s. Everybody's different on when it happens. But the back part of the eye, this whole chamber in the back is filled. So the front part is filled with essentially like water. We call it aqueous humor. The back is filled with vitreous humor, which is more like runny jello. And the vitreous is 98% water. So it's mostly water. About 2% is made up of this stuff called collagen. That collagen is the same thing hair is made out of. Hair. But it's like, looks like little microscopic fibers that run in all different directions, and it makes this kind of loose meshwork in the back of the eye. When you're first born, that actually pushes out against the retina, and it's a protective mechanism. Babies, as they're learning to walk, fall all the time and would be at risk for what we call retina detachment. But the gel actually pushes out against the retina to help hold it in place. But as we age, those fibers shrink, and eventually they shrink and build up enough force that the gel will separate from the back of the eye. So it's very strongly attached. This meshwork of fibers is very strongly attached along the front of the eye. Doesn't separate from there unless there's a severe trauma. But it's fairly loosely attached to the retina, the lining of the back of the eye, and it has a fairly strong attachment at the optic nerve. And what will tend to happen is it'll build up enough force where it will suddenly pull loose this attachment at the optic nerve, and the gel all collapses towards the front of the eye. As we can see it kind of peeled off here and separated. And it's mostly fluid. The gel is mostly water, so it's just water that fills the space behind it. And so we'll see that. And what we usually people will present to our office with is they'll have floaters and flashing lights. The floaters are these little fibers in this gel will clump together in little areas, and they'll make these little like whitish dots that we can see when we look in the back of the eye. And pretty much everybody has floaters of some degree. Some people notice them more than others. But what will happen when the gel separates from the back of the eye is all these floaters suddenly move to new spots. And your brain kind of filters them out as they develop. And so you'll see them for a little while, and then they seem to fade away. And that happens over people's lifetime. All of a sudden, they all move to new spots where you're not used to them, and new ones form. And you see a bunch of floaters in your vision. And those floaters will tend to fade away over a few months, essentially as your brain gets used to them and filters them out, and they go away. And you'll see flashes of light. And what that is as this gel pulls away from the back of the eye, it tugs on the retina as it separates from it. The retina only knows how to do one thing, and that is say light. And so if I took an instrument and just dragged it across your retina, you'd see this streak of light go across. That gel is pulling on it. It can't say something's pulling on me. It just says light. And so you get like a lightning bolt out to the side, like a little flash, and then it's gone. And people say, yeah, it's like I feel like I see lightning out of the corner of my eye. And that usually lasts for about a week. Some people it's a little longer, but essentially once the gel finishes peeling off the edge of the retina, little flashes of light go away, and that takes care of it. Now, when this happens with folks, so if you suddenly start seeing floaters or flashes of light, we want to see you. And the reason for that is that sometimes, so most people, 95% of the time, what's going to happen is this gel is just going to peel off from the retina, separate it from it. You'll have these floaters and flashes, and it resolves. But about 5% of people, what we'll find is that there's an abnormally strong attachment of that gel to the edge of the retina, or there's a weak spot in the retina. And instead of just pulling off, it'll tear the retina. And that's what we see in this top left picture. The gel at the tip, so we call it a horseshoe tear, is what this one is, because it's shaped like a horseshoe. The tip of that horseshoe is where the gel is still stuck to the retina, and it pulls on that spot. And if it pulls enough, it'll tear it, and then the tear will extend out both sides like a horseshoe. We want to catch that right away when it first happens, because what can happen is fluid then can start leaking through where that tear is and lift the retina off the back of the eye. In this lower picture here, you see a classic horseshoe tear, and all this kind of whitish gray color is where the retina is separated from the back of the eye and lifted off. We don't want that to happen. If we catch it really early, before it's separated, so this tear here, there's a little whiteness right around the edge where fluid's starting to want to creep in, but it hasn't lifted off the retina. What we do is take a laser right in the office, and we take and make like little spot welds with a laser. We take a laser, burn the retina, and scar it to the layer below called the choroid, and it creates a barrier so fluid can't get through there, and then the retina will stay attached. This is usually way on the outer edge of the retina, so for most people, this isn't something you're going to notice in your vision. It would leave a little blind spot right there, but it's way off to the side, and most people aren't going to see that at all. Whereas once the retina starts to detach, it causes much bigger problems. So the moral of the story with these is if you suddenly start seeing a big change in floaters or flashes of light, you should call your ophthalmologist and get checked, because we want to see you fairly soon to catch this early. If we don't catch it early, it goes on to what we call a retina detachment. And so this top picture here, you can see where the retina is kind of lifted off and just kind of floating above the rest. The rest of the back of the eye is out of focus because it's focused on this retina that's lifted up. And then there's the tear in the retina where it's detached. The center part of vision is just below where this detached retina is. Retina gets blood flow from two places. The superficial layers of the retina get blood flow from the little blood vessels that you see coursing over the surface of the retina. The deeper layer, where all the light detecting photoreceptors are, gets blood from the layer beneath the retina called the choroid. When you lift the retina off from the choroid, it separates that area from its blood supply, and it's like having a stroke to that part of the retina. So as it lifts off, if it stays off for long enough, which is not very long, that part of the retina, the light detecting cells will die and you won't get vision back in that area. Again, if it's way out to the side, you're not going to notice it so much. If it gets right into the center part of vision, you're going to have a deficit in central vision. And it's always hard to say how much. Some people get a surprising amount back, but it's usually not going to be normal. And so ideally, we want to catch a detachment before it's got in the center. So this top picture here would be kind of an emergency thing where we'd be sending that person to a retina specialist immediately because their macula, the center part of vision, is still attached. And we want to stop that process. And it can sometimes progress fairly quickly, but we want to stop it and fix it before it causes more significant problems. So how do you do that? Well, there's two main solutions. The older solution that we still do sometimes is actually put a band around the outside of the eye, surgically go in and put a band in to push the eye back up to where the retina is so we can get the two next to each other so that we can spot weld the retina down to that lower layer. But we can't weld them together if they're not connected. And so we got to get the retina back against the back of the eye. The other way that's probably done more often now is to do what's called a vitrectomy, where we remove the gel. So that's the top right picture for the folks online. We remove the gel from the back of the eye, go in with a little instrument and actually suck the fluid out through that little tear. We can put different materials, different kind of heavier liquids or gas into the eye that help push against the retina to push it back in its normal position. And then once it's in its normal position, we can take that same little laser, spot weld the retina down, and then give it time to heal. And this bottom picture of the retina here is a retina that's been repaired by a scleral buckle. So this part, the yellowish part of the retina, is pushed up compared to the rest of the back of the eye, where that buckle is squeezing the eye in to hold it down. And then all that yellowish colored area and darker area is actually where laser has been done to seal the retina down and hold it in place. And the idea is we want to save the center part of vision because that's the part you use the most. The laser causes some damage to the peripheral vision, but your center vision is the most important part. So we're trying to save that area. And the key is, again, to catch this ideally before a whole bunch of retina is detached so we can try to get as much of that back as possible. So another problem that we will tend to see that tends to get more common as people age is glaucoma. Glaucoma will affect about 10% of people. And it's actually much more common in African Americans, about 8 times more common. So something we definitely check in that group of folks because there's a much higher risk. And what it is, it's typically a very slow progression, and it affects peripheral vision. So the earlier we diagnose, the better. But you can see in this picture here, kind of normal vision, early glaucoma, and we progress. Normal looks good. In the early section, you can see you hardly see a difference. There's a little darkening out on the outer edges, and then it works its way in towards the middle. And the problematic thing with glaucoma is that usually it's fairly advanced before people know that it's there. People won't realize it till you get into those bottom 2 images. And the issue with glaucoma is we can't reverse damage once it's done. It's preventing it from getting worse. So ideally, we want to catch it when there's no change in your vision at all, that you can't tell any difference, and then prevent it from getting worse. Glaucoma, if it goes on and is untreated, can cause total blindness. It just keeps coming in until everything is black. And we obviously want to avoid that. So what causes glaucoma? Well, glaucoma is a damage to the optic nerve, which is this yellowish nerve that connects the eye to the brain. And that nerve in this bottom picture here is kind of a cross section of it as it comes into the eye, but it's made up of about 1.2 to 1.4 million little nerve fibers. And those you are born with, you don't get any more. And so you're born with a certain number, and our body does not repair or replace those. We normally slowly lose those nerve fibers over time, but there's a lot of redundancy in the optic nerve. And so you can lose probably about half of the nerve fibers and not have any effect on your vision as long as they're equally distributed how they're lost. But because there's a lot of redundancy in those fibers, it won't have a big effect on your vision. But once you get down to where you've lost all the redundant ones, each one you lose, you're losing a little bit more vision each time. So for most people, the rate of loss is so slow, it never gets to the point where it affects your vision. What happens in glaucoma is that rate of loss is accelerated. And the main thought of what causes it, there's a couple things that are thought to contribute. One is blood flow, that maybe people are born with vessels that don't get as good of blood flow to that area. But the main culprit we watch is pressure in the eye. The eye constantly produces a fluid that then drains out. And I think my next slide goes over that. Yep. It constantly produces a fluid in the back of the eye that drains out in the front, and there's an imbalance in that process. For most people, the thought is that the drain doesn't drain as well. It gets plugged up over time, and then the pressure starts to go up. And when it does, it starts pressing on those nerve fibers and it starts to damage them. And it presses the ones on the outer edge first, which are your peripheral vision, and then it works its way in towards the middle. And so one of the main things we watch with glaucoma is what is your eye pressure? And we check it a bunch of ways. So these may look familiar to some folks. There's the air puff test, which people definitely remember because it kind of scares you. It's actually a less accurate way to check it. The way we do it in our office is this bluish light called the Goldman applanator. It actually just touches the surface of the eye, but we put a drop in that numbs it. You don't feel anything. It's much more comfortable. And it's the most accurate way to check it. And then there's a few different newer devices that check it. The old way to do it is called a Schiat's tonometer. And those are not, I've never seen one used. I have one. But yeah, you tip the patient back, you put this weighted thing on their eye, you numb the eye. It looks rather medieval, but it works. But fortunately, those days are gone. And so normal pressure in the eye is about 10 to 22 millimeters of mercury. And the old thinking was that if you're below 22, you don't have glaucoma. And if you're above that, you do, and we need to do something about it. And that's actually not true. What we find is the higher the pressure, the higher your risk. But I have many patients that have a pressure of 25 or 26 and go through their whole life and never get glaucoma. In fact, probably 90% of them won't. More than half of my patients with glaucoma have pressures that are normally within the normal range, but have damage to those nerve fibers. The higher the pressure, the faster the damage occurs too. So if you come in and your pressure's 40 or 50, you're going to lose vision over weeks. But if your pressure's 18 and you have glaucoma, it'll slowly progress over years typically. So that's one of the things we look at is what is the pressure and kind of gauging risk based on that. The main thing we look at is the optic nerve to see if there are signs of damage to the optic nerve. So as these 1.4 million little nerve fibers come into the eye, there's actually a hollow space in the center of the optic nerve through which blood vessels come in through the middle of the nerve. And most people, that hollow space is about half or less of the distance across the nerve. And one of the things we look for is that hollow space bigger, like the picture on the right here at the top. If that hollow space is bigger, that's suspicious for glaucoma. And this would be fairly big. I would call this like 80% of the distance across the optic nerve, so it's bigger than it should be. The problem is everybody's born with a different size hollow space in their optic nerve. Most people, it's about 20, 30%. But I have many patients that it's 70 or 80% and they don't have glaucoma. So it's not as simple as that either. And the way I explain it to patients, it's kind of like you're looking at the end of a hollow log with a hollow space in the middle. If you take a big hollow log with a big hollow space and a small one with a very small hollow space, they can both have the exact same amount of wood in them. And essentially that's what happens with glaucoma. But when we look in the eye, the optics of your eye distort the size. We can't measure the size by just looking at it. Depending on the optics of your eye, can make your optic nerve look really big when it's actually really small or vice versa. And so we need better ways to do that. And one of those ways is this thing called an OCT test. And I think I have, nope, that's the picture I have of it. So we now have the ability with this special camera called an OCT where we can take a picture of the optic nerve. We can draw a circle around the optic nerve and we can actually measure the thickness of those nerves as they cross the circle. So the nerves, as they come in the eye, they make a 90-degree turn and they go out like rays of the sun in all directions. And they're invisible to us looking at them, but my camera can see them. And what it does is gives me a little graph here. As we start in one spot and go around the optic nerve, it measures the thickness of those little nerve fibers, and it compares them to age-adjusted normals. So this black line is the thickness of the nerve fibers in this right eye, and you can see the hollow space in the center of the optic nerve is a little big on this. The green zone is the normal zone, and in this person, you can see that line's way up in the top of the green zone. That's not glaucoma. It's not what that looks like. And so this is very helpful for people that have kind of larger hollow spaces in their optic nerve that we can look and say, yeah, I think this is just normal for you. The old days, we probably would have started that patient on treatment because we'd be worried about glaucoma. Now we can look and say, I don't think that's it. And we can repeat this test and see, it's normal, but last year it was a little higher and it's dropping every year. That's what glaucoma looks like. Then we catch it early. If we find, yeah, it's the same every year, that's not what glaucoma does. And so we can rule that person out. So it's a very helpful test. And here you can see another one here on the bottom. This one on the bottom, where I tend to see glaucoma is where these two hills are on either side of the chart there. And you can see the one to the left there, the hill, that line kind of dips down and drops down into the red area there. That is very suspicious for glaucoma. I would be starting this patient on eye drops. The other test we do is to look at the peripheral vision. So when you come in the office and you read the chart, it's only testing your very center vision. This tests your peripheral vision. So you could be down to all you see is this little tiny circle in the center, and you can still read 20/20 on the eye chart. So totally miss that person. And so what we do is a test called a visual field test, which many of you probably had. Looks like a sideways giant cereal bowl. And there's a target in the middle you look at, and we shine little lights out to the side, and you push a little button every time you see the light. The computer program analyzes your answers and gives us a printout. So this one, the one to the left is normal, where the two lines cross up on the top right corner is right where you're looking. And then out to the side is the vision out in each direction. The light areas are where you see well. The dark areas are where you don't see so well. So there's a black spot in that. And what that is your normal blind spot where the optic nerve comes in the back of the eye. There's no light receptors there. We all have that. So that is what a normal field test looks like. The one next to it on the top here to the far right, you can see the top has this big black arc going across, and that is very typical for glaucoma, where there's loss of some of the nerve fibers. And then the bottom one is advanced glaucoma, where it's closed into a little tiny circle. These little hash marks that you see are each 10 degrees. So this test can test out to, if you do a full test, it can go up to 30 degrees. But this person is down to like 5 degrees of central vision. It's like you put your fist out in front, and what your fist is blocking, that's the only part you're seeing, actually. Everything else is black, and that's very debilitating. We want to prevent that. So the diagnostic criteria for glaucoma, like I said, if your pressure's high, maybe you have glaucoma, maybe you don't. If you have a field change, there's other things that actually can cause visual field changes that may not be glaucoma. So our typical diagnosis is 2 of the 3 characteristics that we look at. The optic nerve and the hollow space is bigger than normal, your pressure's high, or you have visual field tests. If you have 2 of those 3, that's what we're looking for with glaucoma. You can have any one of them and be fine, actually. And then the 4th criteria I would use nowadays is that OCT test, where we took the picture and made the little graph. I find that to be the most helpful in early glaucoma, because stuff shows up there way before it shows up in a visual field test, typically. Because like I talked about, there's a lot of redundancy in those fibers. You have to lose a lot of them before it shows up in the field test. So that picture is usually better for detecting early glaucoma. And then what do we do about it? Well, the whole key, like I said, is to try to catch it early before you have vision loss, because once those nerve fibers are gone, I can't get them back. There's nothing I can do. And then you still slowly lose them over time. Even if we treat it perfectly, we're just trying to slow it down more. So the first step in treatment for most people will be eye drops, and there's a whole bunch of different kinds. And essentially what they do is lower the pressure in the eye pressure. The other early treatment we tend to do nowadays is a treatment called an SLT laser. So if you remember, I talked about fluid is produced in the back of the eye and it drains in the front. In this picture on the top right, where this little green laser is pointing and making these little circles, that's the drain. It goes right around your iris and the cornea, the clear covering of the eye, where the two of those meet is where that drain is. And one of the things we can do is actually take a laser and just irritate that drain a little bit. And what that does is stimulate your body to come in to do repair work. And in the process of that repair work, it cleans junk out of the drain. And in about 2/3 of people, that will lower your eye pressure. It's a 5-minute painless treatment we do right in the office, and that lowers the pressure for many people. And then if none of that works, there's some other options. There's surgery we can do. You don't end up having to send a lot of people for surgery nowadays for glaucoma because our other treatments have gotten so good. But for people the drops don't do the trick, or they're allergic, usually most commonly that they're allergic to most of the drops and we can't use those. The laser didn't do the trick. There's various different surgeries that essentially make a new drain for the eye so that fluid can bypass the natural drain and drain out better. And that's the most invasive of the three, so that's why we save that one to last. So the key is early detection, like we said, ideally before vision symptoms are noted, and then trying to slow that rate of progression to hopefully less than the normal rate of nerve loss over time so we can prevent vision problems. And that's probably the number one reason. So if people who have healthy eyes, they don't need glasses, they'll ask me, well, how often should I come into the eye doctor? And usually I'll recommend, if you've got nothing else going on, at least every 2-3 years to come in and get checked. Mainly for glaucoma, because you can have, fairly significant glaucoma developing and not realize it till it's advanced. And it's very easily caught on a regular eye exam. So moving on, eyelids. So what kind of issues do we see? So there's several different things we'll see with the upper eyelids that people will come in for. The most common is what we call dermatochalasis. And it just means extra skin on your upper eyelid. And most everybody gets that to some degree over time. The person on the top left here, you can see that skin hanging way over the edge of the eyelid and starting to hang down and block vision. And then the next two pictures over to the right are a younger person that has a milder amount, and then after surgery. And essentially the surgery is we numb up the upper lid and we just remove a little strip of skin from the upper lid. That fixes the problem. If it hangs down enough, it'll start to interfere with vision, and then getting that out of the way will help with the peripheral vision. If it's a mild amount, it may not be interfering with vision, but a lot of people just cosmetically don't like the way it looks. We can fix it. It's a fairly easy procedure. And the other common problem that we'll see, so that procedure is called a blepharoplasty, is the name of it. The other common symptom we'll see is the lids themselves drooping. And that you can see in the bottom here. And you can see the skin actually is pulled way up tight, and we'll commonly see that with this. What causes, we call ptosis is the name for it, when the lid itself drops. The most common cause of ptosis with aging is the main muscle that lifts the eyelid is called the levator muscle. And it attaches to this little plate of cartilage called the tarsus on the upper lid and pulls the upper lid up. If that muscle separates from the tarsus, or the muscle just stretches out over time, what we'll find is, the lid goes up and down, the muscle's still working, but everything just drops as it stretches out. What will commonly happen is it'll separate from the tarsus, but it also has a connection at the skin, which is what makes the little crease in someone's upper lid. So the top right picture there, the after surgery one, you can see there's still a little fold of skin and there's a little crease that pulls that skin up. That's caused by that muscle that lifts the lid. It also attaches to the skin and lifts the skin up when your lid opens. When the muscle separates from the cartilage plate and it's still attached to the skin, what will happen is it'll pull that lid crease way up. So this person's lid crease is way up in the top of their orbit because that muscle's pulling the skin, but it's not pulling the eyelid very well. And so we'll see that lift up. And then you can see here, again, a younger person that's got ptosis really just on her right eye, so left as you're looking at her. And then after surgery, and it's lifted the lid back up to where it's supposed to be. And essentially what we do is go in and reattach that muscle or just tighten it up so that it lifts the lid back up into the normal position. And that takes care of it. my starting slide that showed kind of the aging eye, you can see the eyelid changes in this, that here's young baby, lid's pulled up nicely. And then as we age over time, you can start seeing a little extra skin in the second row on the far right, and then a little more extra skin on the next row down, and it progresses. And then as you get to the last two, especially the second to last one, you can see that lid crease is pulled way up by that muscle has detached from their upper lid and is lifting the skin way up high there. And so you can kind of see the normal aging of the eyelids as people progress in age. Babies tend to have an extra little fold. That fold of skin tends to be fairly prominent over their upper lid and kind of covers it. And as they grow, it pulls up out of the way. Cataracts. So that's one of the main things I do is cataract surgery. And so what is a cataract? A cataract is just a haziness of the natural lens in the eye that everybody gets. And that process starts from birth. I was hoping if I could find a good picture of it, but I've seen pictures before where they take a lens out of a newborn, a 10-year-old, a 20-year-old, a 30-year-old, and you can line them all up right in order because the newborns is perfectly clear and they get slowly more hazy and more yellow over time. So you can see in this second picture down on the left, a fairly clear lens, and then the other one has this kind of amber color to it. That is very characteristic of a cataract that's starting to cause vision problems. And the next one further over is just basically brown. They can get all the way to black if they get really severe. As that lens gets more hazy, it starts to interfere with vision. And we'll see a couple things. One is it'll make things look more dark because as the lens gets more yellow and eventually brown, it becomes like you're wearing sunglasses all the time. So one of the things people will come in and say is, yeah, I need extra light. Like I feel like everything looks dark. And that's very characteristic of this type of cataract change. The other change that we'll see is it scatters light. So as the light comes in, it's blocking some of the light, but it also takes the light and scatters it more. So people will say, like looking at headlights at night, I can't drive at night anymore because the lights just totally blind me, especially if it's raining or something like that. And everybody gets that glare to some degree, but the glare is magnified by cataracts. And then as it scatters the light, it also makes the vision more blurry. And so what we'll see is the visual acuity will just start dropping. And that's usually the main indicator for when is it time to do cataract surgery is how's your vision doing? When we fix cataracts, whether I fix an early cataract or a advanced cataract, it's like opening a dirty window. If the window's a little dirty or very dirty, you get the same view when you open it. The end result is the same after cataract surgery with an early cataract or an advanced one, so there's no rush. But all cataracts get worse. Once they start from birth, really. And that haziness initially isn't enough to notice, bother you, but when it gets to where it bugs you, it just keeps getting worse till we fix it. So once it bugs you, that's when it's time to take cataracts out. So people will talk about cataracts being ripe. And really that just means that we can show that it's interfering with your vision. And mostly it has to do with insurance is a big part of it. Insurance are going to pay to take a cataract out if you're seeing 20/20 and not having any problems. There's no reason to do it. So we got to show that it's interfering with vision somewhat, and then insurance will usually cover it. Cataracts are still the #1 cause of blindness in the world. There are many countries in the world that don't have a lot of money, that have some kind of a government provided health care where you get cataract surgery in one eye because you only need one eye to see. If you have a problem with your first eye, they'll let you get your other one done. But otherwise, that's what they do with their limited resources. And there are many countries where there's nobody does cataract surgery, but there's no money for them. And so it's still the leading cause of blindness in the world. Cataracts can be present at birth. Some people are born with them. I start seeing cataracts typically in people in their later 40s, mid to late 40s. It's not unusual for me to take a cataract out in someone that age, and then they get more prevalent as we get older because that lens just keeps getting more blurry. I'll have patients that make it in their 90s and are still seeing 20/20, and we leave them alone. But if we live long enough, we'd all get them. Most people are probably 70s or 80s is pretty typical for cataract surgery. I think I got everything on that slide. Yeah, and we talked a little bit about the glare. So as you get glare, things will get more blurry. The glare, you can see there's a little glare around the lights in the normal eye, but the one with cataracts is just magnified much more. And then you'll also see halos or starbursts, and that just has to do with if you take a point of light and focus it perfectly, you'll see a point of light. If that focus gets blurred for some reason, it starts to scatter that point of light, and you'll either see starbursts of light or halos around light. Both of those are common symptoms of cataracts. So what do we do for cataract surgery? Actually, I got one more slide before then. So the other question people ask, well, how long have they been doing this? When was cataract surgery invented? Cataract surgery is actually one of the oldest surgeries we know of. They've been doing cataract surgery for 5,000 years. They found instruments for a procedure called couching, which is how they took cataracts out for millennia. But they found them in the tomb of King Kasek, I don't know how to say his name, but of the second dynasty in Egypt from 2,700 years before Christ, and also in an Egyptian physician, 2200 BC. For reference, King Tut and King Ramses II, which are ones people have heard of more, were not born for another 1,500 years. So they've been doing cataract surgery for a long time. And if you look online, I didn't want to gross everyone out by putting a video of this on there, but you can go online, and I have seen videos of, it's usually a witch doctor that does it to this day in Africa. It's outlawed in most African countries, but there are still people in remote areas of Africa that do couching. And it's actually amazing watching them do it. It's like 15 seconds and they're done. Part of the key is being fast, kind of like Civil War amputations. You were graded by your speed, not necessarily your accuracy, but essentially what they do, what they found in King Kasekaway's tomb was a copper needle. And essentially what you do is take a metal needle, it's heated in a fire, it's pushed through an area of the eye called the pars plana, which is just about a millimeter into the white part of your eye from your cornea. And that's an area where the retina is fused to the back of the eye. So you won't get a retina detachment. And that's still, if you know people that have injections for macular degeneration, that's where we go in for that. Somehow they figured that out 20 or 5,000 years ago. You take it, you heat it because it'll singe the wound shut. So it won't leak afterwards. They didn't understand, biology back then and microbes and things like that and why you were heating it, or at least we don't think they understood it. You take it, you push it into the eye, and then those little zonules I was talking about that hold the lens, these little fine fibers, you pass the little poker through those zonules, and you just cut them all with a poker by just swiping it by, and the lens just falls into the back of the eye and falls out of the way. And then you go from a black cataract that you can't see anything through other than maybe light to now being able to see blurry images in front of you. They didn't have glasses that we know of at 27,000 BC or 2,700 BC. So you could see, you couldn't see well, but you could at least see something and not walk into things. And so that's the way cataract surgery was performed for thousands of years. So modern cataract surgery, we do not do that in our office the old way. You would not want me to do it that way. The way we do modern cataract surgery is we actually remove the lens from the eye and we put a new lens back into the eye to replace the original one. And so in the top left corner here, you can see the lens behind the iris suspended by these zonules. And then like I talked about, the lens is held in place by there's a membrane that surrounds it that you can think of like a clear plastic bag suspended in the eye by these zonules. And the lens is inside that bag. So the first thing we do on the next image over is, oops, it's not is we take and we first dilate the iris with drops to get it out of the way. And then we take a little instrument where we make a little nick in that membrane that surrounds the lens. And we tear, ideally, a perfectly round circle in that little bag, and we discard that part. You don't need that anymore, but that allows us to get inside of the bag. Once we're in the bag, we take an instrument called a phacoemulsifier, which is just Latin for lens dissolver. And essentially what we do is dissolve that lens. It injects fluid into the eye to keep the eye inflated. It has suction to suck stuff out. And then it has a high frequency ultrasound that dissolves the lens. And typically what we'll do first is make a groove down the center of the lens that goes about 90% of the thickness of the lens through. And then we take and we just crack the remaining part in half. There's different ways to do it, but what way I do it is I'll then rotate the lens 90 degrees, make another little groove, crack that into a quarter, and then we can take the suction on the tip of that and grab a hold of that little piece, pull it up and dissolve it and get rid of it. We want to pull it away from the rest of this bag. So if we just dissolved it back in here, the problem is the front of this bag is about 20 microns thick. A human hair is about 60 to 80 microns thick, so it's very thin. The back of the bag is about 4 microns thick. If you touch that with anything sharp, you'll poke a hole in that bag, and that's what's holding everything in place. If you poke a hole in it, that hole quickly enlarges and everything can fall in the back of the eye. We don't want that to happen. It also holds that vitreous gel into the back of the eye, and that gel has all these little fibers that attach to the retina. We don't want to suck on that gel because we're yanking on the retina and we can make a retina detachment. We don't have to worry about that as long as this bag is intact because it keeps everything in its own separate spot where it's supposed to be. So we pull these little pieces up, we dissolve them in the front of the eye, and then once they've all been dissolved, we take a new lens, and there's a picture of one here on the fingertip. That's how big they are. And that new lens goes back in the eye. In the old days, those lenses were made out of a rigid material. And so you had to make an incision big enough to get the whole width of the lens in. Nowadays, they're made out of a flexible material. And we have an injector that looks like it's kind of like a tapered straw with a plunger. We put the lens in there in a special way. As we push it down, it takes that lens and folds it up like a taco and makes it really tiny. So it will go through about a 2 millimeter incision. And the whole surgery is done through a 2 millimeter incision. And so we put the lens right back inside of that bag and then unfold it. You can see on that the kind of top right image, the second two down, the lens going in. And once it goes in, it kind of wants to go back to its normal shape and open up. We position it where we want in the eye, and that's it. That's what a cataract surgery is. Nowadays, it's about 15 minutes typically for a cataract surgery. It's a painless procedure. You're actually awake for the whole procedure. I could do it with just eye drops, and I have done it that way in patients before. We put eye drops in that will numb the surface of your eye. You won't feel anything, but we have an anesthesiologist there. They give you a little relaxing medication to kind of make you not care. We don't want you too goofy. We get you too out. What happens is you forget where you are, and then you start flailing all over the place, and I don't want you flailing all over the place while I'm trying to operate in your eye. So we want you alert enough to kind of know generally what's going on, that you want to hold still. And there's a big bright light we have you look at. There's a drape that covers everything except for your eye we're working on. So the other eye is covered. And then I have a bright light on my microscope, because it's all done through a microscope that's right in front of you. That bright light just makes this bright blurry haze. So you're not going to see instruments coming towards your eye. Most people tell me they get this colorful, sparkly light show during the surgery. That is just essentially your light. I think what causes it is the light recepting cells kind of firing randomly in your eye, but most people tell me they get this pretty colorful light show. We just get a boring white light to look at, but it's not anything uncomfortable. Most people tell me it was easier than getting your teeth cleaned. And if people are uncomfortable, having problems, we can give them more sedation if we need to, but rarely need to do that. It's not an uncomfortable thing at all. So quick, easy thing. So one of the things we have to thank nowadays for modern cataract surgery is the invention of the intraocular lens. So before that, when you had cataract surgery, you got thick glasses, and I couldn't even hardly find a picture of them anymore, but this lady in the bottom right has what we call aphakic glasses. And you can see they kind of come in, and then there's this round spot in the middle. People talk about looking like Coke bottles. That's probably like a +14 lens. I don't have any patients anymore that have aphakic glasses, but I had many when I first started practicing 20 years ago that had cataract surgery, 20 years before that had aphakic glasses. And these are kind of smaller, more fashionable ones, but still not very fashionable. So that's what you got after cataract surgery, that or a contact lens. Once contacts were developed, we could do contacts that look fairly normal, but you needed a very strong lens to replace the one we'd taken out. Until Dr. Ridley, who was an ophthalmologist in England during World War II, And what he noticed is that fighter pilots would come in that got shot down, and the canopy blew up in their face, and pieces of the canopy embedded in their eye, and they left them there. They didn't have a great way to remove them, but what he found is that they seemed to be inert. They didn't have a reaction to this material, whereas your eye will attack most foreign things in the eye and cause all kinds of problems. So he came up with a bright idea. Why not carve one of these into the shape of a lens and stick it in somebody's eye? So he did some calculations, thought of what he needed to put one in. He was 10 diopters off. So they still ended up having terribly thick glasses. The next patient came out within 1 diopter of normal, of 0 prescription. And so nowadays when we do cataract surgery, we measure the eye beforehand and we select a lens to make your prescription whatever you want it to be. Most people want to have good distance vision without glasses. And then reading glasses for up close is the most common thing that's done still. But and the technology for this has gotten better and better. Like I said, nowadays the lenses fold. So the original lenses were made out of this material called Perspex, or the generic name is polymethyl malacrylate, or PMMA. We still make PMMA lenses. We still use them for certain things, but modern lenses are acrylic so that they'll fold up to go through that tiny incision. And those started becoming, probably the 70s is when those became mainstream, probably the mid to late 70s. And the first lens implant was 1949. So cataracts nowadays, the main goal is still to fix the cataract. So if you got a cataract, I can't clear it up even with glasses because it's like you're looking through frosted glass. There's nothing we can do to make that view clear. So I want to get that hazy lens out of the way. And any lens I put in there, I can make you a pair of glasses to make it clear for distance, near, and give you a trifocal. You'll see distance, intermediate, and near. Doesn't matter what lens we put in. I can correct all the rest with glasses. But there's a whole bunch of options nowadays to try to not need glasses so much. So for everybody, a standard lens, we're trying to correct nearsighted or farsighted. And so I can make you in focus for distance, or I can make you in focus for reading, but one or the other with each eye. Sometimes we even do one eye of each, what we call monovision. If you have astigmatism, a regular lens doesn't correct that. You need what's called a toric lens or glasses to correct it. A toric lens has these little marks here. Mark on this clear lens on the bottom, mark the steep axis. So once we put the lens in, the only difference is we line it up to wherever your astigmatism is, and that corrects that. And then there are lenses that try to get rid of the need for reading glasses. And there's 2 main types of those. There's what's called a multifocal lens, which is one that looks like it has little bullseyes in the bottom right corner. And essentially, those bullseyes alternate between distance and near. And so it splits the light as it comes in, so you get both distance and up close. The main issue is it splits the light. It can cause glare, can make the vision not quite as clear, but it can get you both distance and up pretty close. The one I use more commonly is called an extended range lens, which is this clear one on the bottom. If you look real close, it looks like there's a faint little bullseye. And what it does is it spreads out the focus to give you just as good a distance as the regular lens, but it moves the focus a little bit closer to get kind of arm's length away, but it doesn't get all the way up to up close reading, but then you don't have the drawbacks of some of the multifocals. So the regular lens is covered by insurance, which covers cataract surgery very well. The other lenses, there's additional cost for. And so it depends on how much do you hate reading glasses? Is it worth the extra cost? So there's lots of options, and that's something we go over when people come in for cataract surgery. So moving on, macular degeneration. This is probably the thing I see in my office most commonly that causes vision problems that we can't completely get rid of. And most people get some degree of macular degeneration over your lifetime. And so the macula is this area. If you look at the picture of the retina on the top, you see the optic nerve with little blood vessels coming out. And then next to it's this little kind of discolored area to the left. And that's right where light gets focused, called the fovea. And the area around that, basically between where the blood vessels are on the top of the bottom, we call the macula. And that's responsible for your central 15, 20 degrees of vision is in that area. And that's the part we use for most things. That's where your highest acuity is. And that is what is affected by macular degeneration. So that same OCT picture I showed you earlier of the optic nerve where we can measure the thickness of the nerve fibers. We use that in retina all the time, and we take a picture of the retina, and it's like we cut the retina right down the middle where the area of central vision is, and then flipped it up on its edge. And we can see a cross-sectional image of the retina. Some of them are color, some are black and white, but essentially what you're seeing is the different layers of the retina, and this little dip right in the center is the fovea. Right what you're looking at gets focused right in that little spot in the middle, and this is in all of that areas within the macula. And so we can take these cross-sectional pictures, and we use those all the time for macular degeneration. So what macular degeneration is a condition where we start to lose the light detecting cells around the center part of vision. And we don't really know for sure why it happens. It's thought to be oxidative damage, but the earliest I see it is in people in their late 50s, and then it gets more common. By the time people are in their 80s, 80% of people have some degree of macular degeneration. So pretty much everybody gets it over time. And what we'll see first, you can see them real faintly in this top image on the left, are these little yellowish dots that show up. And the next one over, you see a whole bunch of them. And those little dots are what we call drusen. And they're thought to be a waste product of the photoreceptor cells that normally we should get rid of, and we don't. They start building up. And so when we start seeing, when I tell people, oh, you're getting early signs of macular degeneration, what I'm seeing is just these little drusen starting to develop. And they build up more over years. The dry type of macular degeneration progresses, but it progresses over years to decades. So to go from this first picture here to this second one, that's probably 10 years or more for most patients. It's a very slow change. As these deposits develop, if we take that same OCT picture where we take a picture through the middle, cut it and tip it on its edge, what it shows up as is these bumps in this bottom layer. This white layer is called the retinal pigment epithelium, and that's where that stuff builds up, and it makes these little bumps that are filled with this yellowish material. And what happens is that it starts to build up, it starts to cause damage to the light recepting cells that are right over top. So all these little dots, what we end up with is we start losing the light detecting cells, and it's like you're losing pixels in an image. And the pixels start to disappear, and initially you lose a few of them, and the resolution, you go from high def to regular TV, but you can still see, maybe it affects it a little bit. But as we get more and more, these little areas start to clump together, and the bottom picture on the left shows these yellowish spots develop, and those are areas what we call atrophy, where the light detecting cells have been lost there. And eventually it can get, so this is end stage where all the light detecting cells are missing in that center part of vision. And what that would look like, it's kind of like you're holding your hand out in front of you, right what you're looking at is where your hand is, and you can't see anything there. There's just a big hole in the middle of your vision. Now, the good thing about macular degeneration is, unlike glaucoma that progresses in and can take everything, macular degeneration only affects the macula. So you don't lose your peripheral vision from macular degeneration. But the most important part of vision is the center part. And so it makes it, if you hold your hand in front of what you're trying to look at, eventually if you have a big enough area, you can't, read very well, you can't pass a driving test. You start, looking at people's faces and you can't tell who they are. You have to kind of look next to them. And your peripheral vision isn't very good. So you're 20/20 in the center if you have normal vision. If I go out 15 degrees, you're 2400 in normal vision with no macular degeneration. And that there's not a way to make that better. And so this end stage, you'll see commercials now where they talk about geographic atrophy. That when you start developing bigger areas of atrophy, kind of looks like the country or something. They start to build up, and then eventually you end up center you don't see. And if you look at that on this cross section of the OCT layer is the light detecting cells. When you get right to where the little dip is in the middle, you see the black layer just collapses and it's gone after there's no light detecting cells. Now that process in dry macular degeneration. And so the key is with macular degeneration, really, the longer you problems or something, the less likely it's ever going to get to be a problem. So if you come into my office and you're 85, you have, the top left picture, you're probably never going to have any problems with your vision. But it just doesn't have enough time to cause problems. But if it's starting to look, like this at 70, it's likely to get to where it causes problems. Of the people that have big vision loss from macular degeneration, 80% of them have what we call the wet type, which we're going to talk about next. The dry type, it's only 20% of people, and it's the people that progressed all the way down to this bottom image there. So people hear dry macular degeneration. I usually tell people don't panic because it's very slow. It's a lot likely to get to where it causes big problems. A lot of people with a dry type come in and they see 20/25 is pretty common. So they're not doing bad. Yeah, I went over most of that in this slide. So the one treatment for dry macular degeneration is we found vitamins. We call the AREDS2 formula. They're mostly antioxidants. They slow the progression by about 25%, and they make it about 25% less likely to go to the wet type. And so those are the main treatment for early dry macular degeneration, but there's no way to get rid of it. It just progresses slowly regardless. So the wet type, what happens is it starts out as dry, but again, for reasons we don't completely understand, will start growing abnormal blood vessels into that area. And those blood vessels will first start to leak water, which will distort the retina a little bit and cause things to look wavy or blurry. And then eventually those vessels start to leak blood. And when they leak blood, blood outside of blood vessels is toxic to the retina. So when you have a bleed that happens in the center part of vision, it's going to damage all the photoreceptors in that area, and you're going to lose those photoreceptors, and it can happen very suddenly. So unlike dry macular degeneration that progresses over years to decades, wet macular degeneration can progress over hours to days. It can be very fast sometimes. So what I don't want to see is this when I look into someone's eye, because they've had a huge hemorrhage and they're going to lose many of the light recepting cells in that area, and there's no way to get them back. What we want to catch it is early when it hasn't bled and there's just water leaking, because there's treatments we can do for that. And the treatment, let's see, actually this talks a little bit out. So we'll give people this thing called an Amsler grid, where you look at a little dot. It's just like a piece of graph paper. And essentially, if you start seeing waviness, that's a sign there's distortion in the retina. Or people will come in and say, I look at my neighbor's house and the siding is straight, and then there's this bump in the middle and it keeps going, or the door jamb has a curve in the middle of it. We want to know about that right away, because we can do something about that. As it gets worse and it bleeds, then you'll get this big black spot in the center. And here's, as it progresses with macular degeneration, you can see in the second image down, that black spot, you can still kind of see through it a little bit. There's some light detecting cells. The bottom one is just black. There's nothing there, because all the little light detecting cells are gone, and we want to catch it before that. The treatment for the wet type of macular degeneration, so dry type, like I said, we can slow it down. We can't make it go away. We can make the wet type go back to the dry type, because we can make those vessels go away. But the key is to catch it before they bleed and cause a bunch of problems. And we do that, the modern way of doing it is with a medication that's actually injected into the eye. Sounds terrible, but just like cataract surgery, those same drops, put drops in your eye, you won't feel a thing. I can literally cut your eye open to do cataract surgery and it won't bother you, won't feel anything. We can stick a little tiny needle in through there and you don't feel a thing. We inject a little tiny bit of fluid. We used to inject more. The one thing people would feel is the change in pressure, because we're injecting more fluid. It makes the pressure go up in your eye. They now use half the amount of fluid that they used to use. And so many people that I have get these say, yeah, most of the time I don't feel anything. It's not bad at all. It takes, less than a minute. And essentially they inject this fluid, a medication called the anti-vascular endothelial growth factor. And what that does is it blocks this substance that the retina produces called vascular endothelial growth factor that causes these vessels to grow in and leak and cause problems. When we block that, it gets the vessels to shrink and go away. And so the key is to get them to shrink and go away before they bleed into the retina. And the medication, it's usually a series of 3 injections a month apart. And then they'll kind of watch and see. We used to watch and see, oh, if the vessels start coming back, then we treat you again. But what we find is, well, the vessels come back and they might bleed again before we see you. And then we've lost a bunch of vision. So now what they'll do is they just keep extending the injections by more and more each week. And I'll have some people that, don't need them anymore, or doing them every, 3 months or something is not too unusual. And they're working on technologies to make it last longer. So they do an injection and maybe you don't need one for a year or never again. I think this last thing I'm going to talk about is a stroke to your eye. So stroke is essentially a blockage of blood vessels to somewhere that there's no other blood vessels that go there. So in your eye, you can have a stroke in the eye itself. And this, top image shows there's a little tiny clot. I don't know if you can see it there, but there's a little tiny clot that's blocked this artery, and the area downstream from it is all turned white. And that's what we call a branch retinal artery occlusion. If it's a vein that blocks, blood gets pumped into the eye and it can't get out. So it bursts a whole bunch of capillaries. This is a central retinal vein occlusion where the main vein exiting the eye is blocked. So blood's getting pumped in and it's popped a whole bunch of capillaries, and that can interfere with blood flow. And then you can have a regular old brain stroke that affects the occipital lobe. So these white areas here are where it didn't get blood flow, and that causes loss of vision. With a stroke to your brain, as vision comes in from each eye, both eyes see both the right and the left. So if you close one eye, you can still see the other side of the room by your peripheral vision in both eyes. But as that information comes into the brain, this bottom picture shows here, the purple is your vision off to the left, and part of that's out of your right eye, big chunk of it's out of the left. As that information comes in, the 2 optic nerves cross. All of the information from the left part of your vision in both eyes goes to the right side of your brain, and vice versa. So if you have a stroke in your brain, the classic image is this, where if you close either eye, it's like there's a black line and you can't see on one side and you can see on the other, and it's in both eyes. So the right side or the left side of space will disappear. We call it a homonymous hemianopsia. And that's the sign of a stroke affecting the brain. And the key is identifying that quickly, because you can get treated with a clot buster drug to try to break that up, but you have to get it within 90 minutes of when it started, which is not much time to get to the hospital, get the workup, find out you don't have a brain bleed or something that would kill you if we gave you that medication, and get the medicine. So it's important to go immediately. So if you ever have half your vision disappear in both eyes, you need to be in the car to the hospital immediately. And then the other is if you have a vessel block in the eye itself, essentially the visual effect will be only in the one eye. So you close the other eye, it's completely normal. The eye that's affected, it'll be just whatever quadrant the blood vessel goes to. So the blood vessels, as they come in, they split into top and bottom, and then they split into right and left. And so it's usually a quadrant that you'll lose vision in that will disappear. And so the outcome depends on how many blood vessels and which one are blocked. There's no treatment for this when it happens. It's hopefully it doesn't block the blood flow completely and we retain some of the blood flow to that area. Your body will clear up the blockage over time and restore blood flow, and sometimes people will get a fair amount of vision back. Yeah, that's basically it. So people ask me, like, what can I do for the health of my eyes? And it's basically the same things you do for your health of everything else. Eating well, don't smoke. Smoking quadruples your risk of wet macular degeneration. Strokes to your eye or your brain, substantially higher risk. Exercising, all the same things you do, and then a regular eye exam to make sure we're not missing glaucoma or something like that. With that, I'll open it up to questions.
If you can say something about dry eye.
Yeah, so I probably should have put that in here. So dry eye is the most common thing I see people for. More than half of people I see today have some degree of dry eye. And there's a lot of things that go along with it. A lot of it just has to do with not producing tears as effectively. over time. I see people with all different ages, but it definitely gets more common over time. Tear production, most of your normal tears are actually produced on the surface of the eye. When you cry, it's your lacrimal gland, which is basically water that's coming out. But the normal tear film of your eye is made up of 3 different types of tears: a mucus layer that helps to stick tears to the surface of the eye better, a watery type of tear, and an oily layer that helps to coat the surface, and that oil makes it so the water evaporates less quickly. It kind of insulates the surface. And dry eye is caused by a deficiency of one of those layers, or all of them, but it can be any one of them. And the main treatment we start with is just artificial tears, adding more tears. For many people, artificial tears, when it bugs you, will solve it. But I have many people that have more severe dry eyes, and it's just a chronic problem. There's not one magic bullet that makes it go away for most people. Usually what I'll start with is artificial tears of various thicknesses. So when you go to the store, there's a whole bunch of different kinds. It's hard to tell which one to get, but as they get thicker, there's more oil in them, and they coat the eye more and stay around longer. But when they get real thick, they go all the way up to like Vaseline consistency, which will last all day, but it makes this oil slick that you can't see through very well. And so it's trying to find a balance of oily enough to last for a while, but not so oily as to blur your vision. And so it's a little bit of experimenting to try to find the right thickness for, based, and everybody's different. I'll have some people that use the super thick stuff and love it and feel like it doesn't interfere with their vision. So it can be different for different folks. Tears drain by little tear ducts by your nose. There's one on the upper lid and one on the lower lid, and they drain away from the eye. And so the next thing I'll usually do is put a plug in the drain on the lower lid. It's just a little silicone plug, look like a miniature arrowhead that just pops in there, and it's removable. So for any reason you don't like it, I just pull it right back out. Takes like a minute to put in the office, doesn't hurt or anything. And essentially what that does is makes the tears that you put in or that you make stick around longer. They don't drain as quickly. I'll usually just plug the lower one off, so the upper drain is still open. So if you have extra tears, there's still somewhere for them to go. But that's another quick and simple thing. And then the third main treatment there's different drugs. You'll see them advertised on TV, Restasis, Xiidra. There's a bunch of different ones that help. They're anti-inflammatory. If you have any inflammation around the eye, it interferes with tear production. And so by blocking that inflammation, it can make your tears, make tears better. And some people, those will make a big difference. Some people not. Most of them are expensive. Depends on if insurance covers them or not. But Restasis is probably $100 a month. Xiidra can be a few $100 a month. There's a new one called Mibo, which you can buy for like $20 in Europe, but here it's $800 a month. And so, nobody's going to pay $800 a month. So those are kind of the main 3 things we do. And then I look for signs of other things. If you have allergies that are affecting the eyes, that's going to cause inflammation and make you not make tears. So we do anti-allergy drops. Sometimes I'll do a warm compress that helps open up the little oil glands that drain oil from the, that produce the oil that's part of the tear film. There's a variety of things, but for many people, some people, like I said, it's just teardrops as you need it, and that solves it. People with more chronic eyes, dry eyes, it's a lot of times a lot of experimenting to try to find something that controls it. It's not like I will find, especially, I think more so in women, ophthalmology, them have dry eyes for 5-10 years, and then all of a sudden it's so I find that anybody will have it, where they'll have it that bothers them terribly for a while, then all of a sudden it's like, but it's hard to say.
2 questions. First one is a visual acuity. Second one is from your introduction, preventive. Visual acuity, why do eagles have such better visual acuity than humans? And then number 2, preventively, when you swam to Catalina, what kept you from getting eaten from lunch? Like
Yeah.
a seal?
So eagles have a higher concentration of photoreceptors. So different animals have different concentrations of photoreceptors in their eye, how tightly they're packed, and that affects their acuity. And I don't know exactly the details for eagles, but I think that's the main reason is they just have a better visual potential because their acuity is, their photoreceptors are more tightly packed than other animals. As far as for not getting eaten by lunch, some of it's luck. You just got to not worry about the sharks. They do watch in the boat for sharks, and they're watching for, they'll see sharks periodically there. Actually, the whole area is a great white shark sanctuary. So there's a lot of white sharks, which are the ones that you don't want to see. But they tend to hang out deeper, and they're usually attracted by something else. I used to say there was no record of a long distance swimmer being attacked by a shark in a long distance swim, but that's actually not true. There's two cases I know of. One was the English Channel in the early 1900s. Thresher sharks came after a swimmer who was pulled from the boat. And I don't know if they just overreacted or if they really would have attacked, but that type of shark can be aggressive. So the swimmer wasn't bit. The other was at Catalina. About 5 years ago, there was a swimmer that was bit by a shark early in his swim. I think like 4 miles into a 20-mile swim. Didn't tell anyone and completed the swim. It was a small bite. It wasn't like, they took his leg off or something. He got bit. I don't even know if he knew he got bit at the time. And actually, there's a third I know of, what's called a cookie cutter shark in Hawaii. There's a swim between two of the islands where 25% of the swims are aborted because of aggressive shark activity. And a guy was bit by what's called a cookie cutter shark, which is a smaller shark, and it comes up and it takes just a bite out of your flesh. And he thought he got stung by a jellyfish, but when he rolled over, one of the guys in the kayaks who was a local knew what it was, and they pulled him from the water because they'll just keep coming up and taking little bites. So those are the 3 instances I know, but it's not very common. I did see sharks actually at the end. Most of my swim was in the dark. I was swimming through what are called sea pickles, like the first 10 miles in the dark. Had no idea what they were. I thought I was swimming through seaweed, but there was all these they about the size of pickles. They feel like gooey, like a jellyfish kind of. But I thought I was just swimming through seaweed, but I was swimming through those. And then it wasn't until the very end when I was coming into shore, I saw about 8 sharks, all of which were maybe about 3 feet long. And as soon as I saw them, they took off. They were more afraid of me than I was of them. So.
We've got a question online. Have you heard of any correlation between Ozempic and optic nerve damage?
I am not familiar with any with Ozempic. I have not heard of that happening. There are several different medications that can affect the optic nerve, and that would be an unusual effect of optic nerve damage from Ozempic. So I'd have to look that one up. Many medications, almost every medication you will see as the side effect list blurred vision. And that's usually code for dry eye. Is usually the culprit. There are several medications that are known to affect the optic nerve. But yeah, I'm not familiar with that one causing that. Yeah.
UV light exposure, does it actually contribute to any of these conditions?
Yeah, so there's a lot of debate about that. So you'll hear a lot of talk now about blue blocker glasses for screens. As we're on screens, they tend to have more blue light. And some people will propose using these blue blocker glasses for that. I think the best, and there's several other conditions that affect the retina, where wearing sunglasses has been put out as one of the things people recommend for treatment. But there's actually very little evidence that blue or ultraviolet light damages the eye. The best case I can give for that is when we do cataract surgery. You saw the lenses when I showed them. Some of them were clear and some of them were this yellow color. The lenses I put in are this yellow color. And one of the thoughts was that a cataract, as the lens gets yellow, it blocks blue wavelengths of light. And that when we take cataracts out and put a clear lens in, we're actually getting rid of this natural protector. And that maybe is why people get macular degeneration or are more prone to it. We see more macular degeneration, probably actually just because people live longer. And so we see more of that. But so what they came out with about 20 years ago is these lenses with a yellow chromophore included in the lens that blocks blue light. So when I do cataract surgery, I put a blue blocker lens in every one. Doesn't affect your color vision, but it blocks that blue wavelength of light. And what we found is there's no difference in the amount of macular degeneration we see in people that have it and don't have it over 20 years since they've been available. So most of the evidence has been anecdotal, that there's some theoretical evidence that may make a difference, but in the actual world, most studies that have looked at it over a long period of time have not been able to find any big difference. The other thing was cataracts, that cataracts are caused by blue light, makes them occur more commonly. But they've done studies that look at people that live at the equator and people that live up near the North Pole, where they spend half the year in no light, and found that the rate of cataracts when they develop cataracts is the same. There's no measurable difference.
Okay. As a
Yeah.
swimmer, I enjoy having my goggles on. Is there any risk of having the goggles on too tight or too loose, or will they cause any other issues?
Theoretically, it depends on the type of goggles you wear. So I wear Swedish goggles, which have they fit actually in your orbit and there's no pad on them. Some people love them, some people hate them, but I've always kind of wore those, and they actually kind of put some pressure on your eyes. Theoretically, that could make your eye pressure go up and cause glaucoma if you were wearing them all the time or had them on super tight. Most goggles that have padding actually rest on the bones around the eye and the orbit, and they're not going to press on your eye, so they wouldn't cause any problems. So there's been nothing that's reported that I'm aware of, and people swim without goggles too. In freshwater, there's probably more of a risk of an eye infection depending on what kind of water you're swimming in. In salt water, it can irritate your eyes after, especially if it gets real salty. It can be very irritating. But, yeah.
Excuse me, one more question from online. When do you recommend starting those AREDS 2 vitamins like preservation?
Yeah, so the study that looked at it looked at people that have a family history of macular degeneration, that have early changes of macular degeneration, like the small drusen that are hardly detectable, moderate or more advanced. And what they found is with the family history or even early macular degeneration, they made no difference over 10 years of the study. And so it doesn't seem to affect things substantially until you reach kind of moderate to more advanced stages of macular degeneration. When I start seeing, pretty readily visible drusen on the eye exam, that's when I usually will talk to people about starting the AREDS vitamins is at that point. We can get a microphone up here. We got a bunch of questions in the front here.
I saw the word on the screen, but I didn't hear you address it. Monovision.
Yeah.
Do they still put monovision lenses in someone who has cataract surgery?
Yeah, we do it all the time.
Oh.
So monovision essentially just means we're correcting one eye for distance and one eye for up close. And we do it in a variety of things. Some people just be born that way. We most commonly do it with contact lenses. And so if you have contacts that just correct for distance, it doesn't get rid of the problem with reading glasses for up close. They make multifocal lenses that split the light, which some people will like. Some people feel like it's just not as clear. And then the other way around reading glasses is to do monovision. And for most people, what will happen is your brain will just favor the clearer eye and ignore the other eye. And we do the same thing, with cataract surgery. And it doesn't one of the nice things about it is, if you don't have astigmatism, at least, it doesn't require any special lens. So some of those special lenses to try to give you up close, there's extra cost. We do monovision with no additional cost because I'm just putting the same lens in. I'm just doing one for distance and one for near. Not everybody likes it. I'd say 80% of people, it works great. Of the other 20%, probably half of them will get used to it over a few months and find that it works pretty well. About 10% of people just don't like it. They just can't ignore the other eye. And the only way to know is to try it. And so most people I do monovision with cataract surgery with are people that have either born that way or done it with contacts or had LASIK for that and know it works well for them. I'll occasionally have people that have never done it that will do it with cataract surgery, but most people will say, if I don't like it, then. And I can undo it. So if we do it and you hate it, I can make you a pair of glasses that just reverse, that correct both eyes the same, and that solves the problem. So it's not the end of the world. It does affect depth perception some. So it's not like, if you cover one eye, technically you have no depth perception. You can still judge depth by size, and people that are used to that are very good at it. But I'm not taking away the other eye, I'm just making it more blurry. And so people still have depth perception, it's not quite as good. So someone who's like a professional airline pilot, yeah, maybe not the best, or they could do it and wear glasses when they're, landing the plane, would undo the monovision. So I do have pilots do monovision actually sometimes, but there are certain circumstances where people will be like, yeah, if it affects depth perception, I don't want to do that.
Does a hobby where you have close vision or even a lot of reading, does that accelerate nearsightedness?
That's a good question, actually. So yes, I would say yes hesitantly. So they've looked at what causes kids to become more nearsighted as they grow. And certain cultures, it's more common. There's some differences in it, but it's thought that essentially your eyes grow to be in focus where you're using them. So if you're reading all the time up close, you're more likely to become nearsighted. And the classic study they looked at is high school kids who graduate and go off and get a job in the trades or doing something else versus those that go on to law school, because apparently lawyers read a lot, and look at how nearsighted they become. And the group that goes to law school becomes significantly more nearsighted than the group that does not. They've also looked at a variety of other things with that, including sunlight exposure. So someone talked about blue light. So if you look at kids who play outside a lot versus kids that are indoors, the kids that play outside become less nearsighted than those that are indoors, regardless of whether they're doing near things. There were a bunch of studies that looked at COVID and how that affected kids, and many of them show an increase in nearsightedness for kids during that period of time because they weren't outside as much. And so there's some theories of that. There's some theories that propose like having kids wear reading glasses for up close. One of the main things we look at in the office is it's fairly easy to do what we call over-minusing. So when we do exams on kids, we'll dilate their eyes to paralyze their focusing muscles so they can't focus to change their prescription. I'll find some kids will come in and we'll get a prescription of like 0 for them, and then we'll paralyze their focusing muscles, and they're actually 2 units farsighted. They're focusing to make up the difference all the time. Or a kid will be, we'll get a prescription of -2, and we'll paralyze their focusing muscles, and we find their prescription 0, because they will, when they're looking at the chart, if you focus, as I reduce the letters or keep giving you more minus power, it makes the letters look smaller, but it also makes them look bolder. And some people will like that and will want more minus power. And so the way we can correct that or find that out is paralyze the focusing muscles, and we'll get a grossly different prescription. And we don't want to overcorrect those kids, or it may actually cause them to become more nearsighted. Because they're doing that focusing all the time, their brain thinks they're looking at something up close when they're not, and it can make the nearsightedness worse potentially.
So, thank you. Do you have a few more minutes if someone comes up?
Yeah,
to
of course.
ask you?
Yeah. I'll stick around
Otherwise,
for
they
sure.
can make appointments with me and I'll just send them.
All
through.
right, all right.
Thank you. That was just.
Well, thank you for having me.
Was excellent. Yes. Yeah, this little. Okay, good.